All right, so today we're taking a deep dive into endocrine hypertension.
Oh, cool.
You were wanting to learn about this topic, and you provided a great source for this.
Excellent.
We have a 2023 review article
Okay.
from Hypertension Research called
Nice.
Endocrine Causes of Hypertension. So basically, we're going to be your guides on this topic. We're going to be like the endocrine hypertension detectives for the next little bit. And hopefully you'll walk away feeling like you've gotten a crash course in high blood pressure, but without needing to go to medical school.
That's a great goal. It's definitely a fascinating topic.
Yeah, I think so too. I'm excited to learn more.
Me too.
Um, so let's set the stage a little bit. We hear about hypertension all the time, but what exactly makes secondary hypertension different?
Well, with secondary hypertension, there's an identifiable cause.
Okay.
Unlike primary hypertension, where the cause is, more of a mystery.
Right.
And even though secondary hypertension only accounts for about 5 to 15% of cases, it's still really important to be aware of the potential culprits because, you suspect something is not quite right with your blood pressure.
Right.
Then knowing these things could be very helpful.
Okay. So in this sea of potential causes of secondary hypertension, it sounds like endocrine disorders are like kind of the big fish.
You got it.
Okay.
Hormones, they play such a critical role in regulating blood pressure.
Right.
And when our endocrine systems get a little out of whack, it can really throw things off balance, and your blood pressure can be one of those things.
Got it. Now, I remember learning about this thing called the renin-angiotensin system.
Yes.
But to be honest, it's all a bit fuzzy in my mind.
Of course.
So could you maybe give us a quick refresher? Like, what exactly is the renin-angiotensin system, and how does it actually work?
Absolutely. So think of the renin-angiotensin system. We call it the RAS for short.
Okay.
Think of it like a thermostat for your blood pressure.
Okay.
So if your blood pressure drops, the kidneys, they release this enzyme called renin, and that kind of kicks off this whole chain reaction.
Got it.
That ultimately leads to the production of angiotensin II.
Okay.
And angiotensin II, this is a very powerful vasoconstrictor, meaning it tightens up those blood vessels and boom, your blood pressure rises.
Ah, okay. So the RAS is kind of like this central control center for blood pressure.
That's a great way to think about it.
Yeah. But I'm still a little bit unclear on like how exactly do endocrine disorders kind of mess with this delicate system?
Well, some endocrine disorders, they can sort of hijack the RAS
Okay.
by either, producing way too many hormones
Okay.
that just, jack up your blood pressure directly.
Right.
Or they can interfere with that delicate balance of the system.
So we've got these hormonal hijackers, basically.
Hey, you could think about it that way.
Causing all this chaos.
A little bit.
So for our deep dive today, can you introduce us to the main suspects that we're going to be looking into?
Absolutely. So we're going to be focusing on primary aldosteronism, pheochromocytomas and paragangliomas,
Okay.
Cushing syndrome,
Okay.
and acromegaly.
Right.
Each of these has its own sort of unique way of really pushing that blood pressure up.
Got it. And those all sound a little bit intimidating.
They can be, for sure.
So I think let's start with this one called primary aldosteronism.
Okay.
It sounds a little scary.
It can be.
What is the deal with this one?
Well, it's actually the most common endocrine cause of hypertension.
Oh, wow.
And so understanding it is really key.
Okay.
And in some specialized centers, it's estimated that up to 18% of patients have this condition.
18%.
Yes.
That's a lot higher than I thought it would be. What makes primary aldosteronism so tricky?
Well, think of it this way. It's kind of the sneak thief of endocrine hypertension.
The sneak thief.
Yes.
Okay.
It's all about excess aldosterone, this hormone produced by the adrenal glands that helps regulate salt and water balance. But in primary aldosteronism, those adrenal glands, they kind of go rogue and start churning out way too much aldosterone.
So too much aldosterone, how does that actually lead to high blood pressure?
Well, all that extra aldosterone basically causes your body to hold on to sodium.
Okay.
And where sodium goes, water follows.
Of course.
So this increases your blood volume, and guess what? It sends your blood pressure soaring.
So it's like your body's turning into one of those like walking water balloons?
Kind of, yeah. You could think about it that way.
Yeah. But hold on, you mentioned something earlier about potassium. What's the connection there?
Yeah, so that's where primary aldosteronism gets even sneakier.
Even sneakier, okay.
You see, high aldosterone often leads to low potassium.
Okay.
also known as hypokalemia,
Okay.
which can cause all sorts of fun things like muscle weakness, fatigue.
Right.
But here's the catch.
Okay.
About half the folks with primary aldosteronism have totally normal potassium levels.
Oh, really?
And that makes it even harder to diagnose. Oh, wow. So you're saying even if my potassium is normal, I could still have this. That's kind of scary.
It is concerning.
Yeah.
Especially because primary aldosteronism isn't just about having high blood pressure, right?
Right.
You might be surprised to know that primary aldosteronism can actually be more damaging to your heart
Really?
than regular high blood pressure, even if your blood pressure readings aren't super high.
Oh, wow. So that is really serious stuff. So we're talking about a higher risk of heart attacks, strokes,
Yes.
possibly atrial fibrillation.
Absolutely.
Okay.
And it can also directly damage your arteries and kidneys.
Wow. So this is definitely something you want to catch early.
Exactly.
Okay, this is all starting to make a lot more sense now. But how on earth do doctors actually diagnose this sneak thief if it's so good at hiding?
Well, one of the key clues is resistant hypertension.
Okay.
That means your blood pressure just stays high,
Uh-huh.
despite being on, at least 3 different types of blood pressure meds, including a diuretic.
Right. Which helps you get rid of extra fluid.
Okay.
So if those meds aren't doing the trick, then primary aldosteronism, it might be the reason why.
Okay, so resistant hypertension is one red flag.
Yeah.
What else should kind of raise suspicions?
If someone relatively young develops hypertension,
Okay.
so especially someone under 40,
Okay.
that's a sign to maybe dig a little deeper
Okay.
because it might not always just be lifestyle factors at play.
Right.
There could be something else going on.
Okay, so younger age, resistant hypertension, what other clues?
A sudden spike in blood pressure or even just a rapid worsening of, pre-existing hypertension, that can also be a tip-off.
Okay, so any kind of dramatic change in blood pressure
Right, exactly.
warrants a little further investigation.
Exactly.
Because it could be primary aldosteronism
It could.
or some other endocrine issue.
Right.
Okay, so let's say a doctor suspects primary aldosteronism. What kind of tests are used to confirm that suspicion?
Well, the first step is a blood test to check the aldosterone to renin ratio.
Okay.
We call it the ARR.
The AOR, all right.
And this compares the levels of aldosterone and renin,
Okay.
which is another hormone that helps regulate blood pressure.
Uh-huh.
So if the ARR is high, it suggests that the adrenal glands are just pumping out way too much aldosterone.
Got it. So the ARR is kind of like the smoke detector.
Exactly.
It alerts us that there might be a fire, but we need more investigation
Exactly.
to confirm it. So what happens after the ARR?
Well, to confirm the diagnosis, doctors, they use some special tests that actually challenge the body's ability to suppress aldosterone. It's like putting those adrenal glands to the test.
Oh, okay. How do they do that?
Well, one common method is the saline infusion test,
Okay.
where a salt solution is given intravenously.
Right.
And if the aldosterone levels stay high despite that salt overload, that's pretty strong evidence for primary aldosteronism.
Wow. So we're basically trying to trick the adrenal glands into showing their true colors.
We are.
That's amazing.
It is. And once primary aldosteronism is confirmed, then doctors have to figure out, is it unilateral, so one adrenal gland, or bilateral, meaning both are involved. And that helps guide the treatment decisions.
Makes sense. How do they figure out which adrenal gland is the troublemaker?
Well, the gold standard is this procedure called adrenal vein sampling.
Okay.
It sounds fancy, but it's basically taking blood samples directly from the veins that drain each adrenal gland
Okay.
and comparing their aldosterone levels.
Got it. So we're kind of like comparing the aldosterone output
Exactly.
to pinpoint where it's coming from.
Exactly.
Okay, that's fascinating.
It is.
I think we've spent quite a bit of time on primary aldosteronism, though.
We have, yeah.
Which is really interesting. But let's make sure we give some time to these other endocrine troublemakers.
Right.
What about pheochromocytomas and paragangliomas?
Yeah.
Those are really hard to say.
They are, but don't let the names intimidate you.
Yeah.
They're, pheochromocytomas and paragangliomas. We'll call them PGLs for short.
PGLs, all right.
These are tumors that arise from nerve tissues,
Okay.
but they can really create havoc on your blood pressure.
Oh, wow. Nerve tissues. So we're talking about the nervous system?
Yes.
Sort of going haywire and causing blood pressure problems?
You could say that.
Yeah.
These tumors produce an excess of catecholamines like adrenaline and noradrenaline, the hormones involved in that fight or flight response.
Ah, okay. So it's like your body's stuck in fight or flight
Exactly.
24/7.
Yes.
Oh, man, no wonder these No wonder people with these tumors have problems.
They do.
What kind of symptoms are we talking about?
The classic trio is headache, sweating, and palpitations.
Okay.
Like an intense adrenaline surge that just won't quit.
Yeah, that sounds pretty miserable.
It can be, and if it's left uncontrolled, it can be dangerous.
Yeah, I bet. So, like, what are we talking about? What kind of dangers?
So we could be talking life-threatening hypertensive crises where blood pressure just skyrockets, heart damage, and even stroke.
Wow. Okay. So these PGLs, while they're rare, they're definitely not something to mess with. How do doctors even begin to diagnose something like this?
Well, the first clue often comes from those classic symptoms we talked about.
Go ahead.
But to confirm the diagnosis, doctors will look for elevated levels of metanephrines
Okay.
in the blood or urine.
Okay.
And metanephrines, those are actually the breakdown products of the catecholamines that we were just talking about.
Okay, got it. So metanephrines are kind of like the calling card of PGLs.
Yes, you can think about it that way.
High levels, something's off. So what's the next step?
Once those metanephrines raise a red flag, then imaging studies like a CT or an MRI scan are used to actually locate the tumor, see how big it is, and get some other characteristics of it.
Okay, so blood or urine test.
Yes.
And then imaging. Got it.
Exactly.
Okay. Let's move on to Cushing syndrome.
Okay.
This is the one with excessive cortisol, right?
Yes, exactly. So Cushing syndrome is all about prolonged exposure to high levels of cortisol, a hormone naturally produced by those adrenal glands.
Right.
It's less common than primary aldosteronism, but it can still have some serious consequences for your health, including, your blood pressure.
Right. Of course, cortisol is often called the stress hormone. So are we talking about like chronic stress being the main driver here?
Well, chronic stress can definitely play a role, but Cushing syndrome is usually caused by a tumor,
Okay.
either in the pituitary gland, which is what controls cortisol production, or in the adrenal glands themselves.
So we've got another kind of hormonal power struggle going on.
Yes.
But how does this cortisol overload actually lead to hypertension?
Well, think back to our discussion about primary aldosteronism.
Okay.
Cortisol, when it's in excess, can actually mimic the effects of aldosterone, causing your body to retain sodium and water. And as we know, that increased fluid volume, it's going to drive up that blood pressure.
Oh, so even though they have different root causes, they can both hijack the blood pressure system.
Exactly.
That's interesting. So aside from high blood pressure, what are some other signs that should raise suspicions for Cushing syndrome?
Well, some classic signs include weight gain, especially around the abdomen,
Okay.
those characteristic purple stretch marks, muscle weakness, and of course we can't forget about moon face,
Right.
which is kind of a rounding of the face that's often associated with Cushing syndrome.
So some pretty noticeable changes.
Yes.
What kind of tests are used to actually diagnose Cushing syndrome?
Well, there are a few ways to measure cortisol levels.
Okay.
A common approach is a 24-hour urine collection.
Okay.
This gives doctors a really comprehensive picture of, how much cortisol your body's producing over a whole day.
24-hour urine collection. Okay. Are there any other ways to catch those sneaky cortisol levels?
Yeah. Another option is the dexamethasone suppression test.
Okay.
Dexamethasone is a synthetic steroid that should normally suppress cortisol production. But in Cushing syndrome, cortisol levels just stay high,
Right.
despite the dexamethasone, which is a sign that something's wrong.
Wait, so you're giving a steroid to suppress a hormone?
I know it seems a little counterintuitive.
It does.
But remember, dexamethasone, this is like a synthetic version of cortisol. So by giving a very controlled dose, doctors can really see, okay, is the body responding the way that it should to, kind of that feedback loop that regulates cortisol production?
Oh, that makes a lot more sense. So it's another one of those challenge tests like we talked about with primary aldosteronism.
It is.
Okay.
Exactly. And then finally, there's the late night salivary cortisol test.
Yeah,
So this one's pretty simple. You just collect a saliva sample late at night.
Okay.
Cortisol levels should be low at night, but in Cushing syndrome, they stay elevated.
Mm-hmm.
And that can disrupt your normal sleep-wake cycle.
Wow, saliva. I wouldn't have thought of that. So we've got a couple different ways to check these cortisol levels. What happens once Cushing syndrome is confirmed?
Well, the next step is to figure out what's causing it, right?
Right.
So is it a pituitary tumor or is it an adrenal tumor?
Right.
Doctors measure the level of ACTH, which is a hormone produced by the pituitary gland that tells the adrenal glands to make cortisol.
Oh my God.
So if ACTH is high, it points to a pituitary tumor.
Okay.
If it's low, then it points to an adrenal tumor. And then imaging studies, like an MRI or CT scan, are then used to really confirm, is there a tumor?
Right.
Where is it?
Okay, so I'm starting to feel like an endocrine detective
He's
here.
doing great.
This is very cool.
Yeah.
So we've covered primary aldosteronism, pheochromocytomas and paragangliomas,
Yes.
and Cushing syndrome.
We have.
It's incredible how many ways the endocrine system can mess with our blood pressure.
It's fascinating.
It is. But we have one more major player to discuss.
Yes,
right?
we do.
And that is acromegaly.
Yes, the growth hormone disorder.
Acromegaly, that's the one with excessive growth hormone, right?
Yeah.
I remember reading about people that have like enlarged hands and feet. But how does this fit into like the whole hypertension puzzle?
It's kind of a shapeshifter when it comes to hypertension. So it's caused by a tumor in the pituitary gland.
Okay.
That produces way too much growth hormone. And this excess growth hormone, it can affect your blood pressure in several ways.
Okay.
It can lead to fluid retention, which we know increases blood volume and pressure.
Right, right.
It can also worsen insulin resistance, a condition where your body doesn't use insulin efficiently.
Okay.
And that can contribute to hypertension as well.
Okay. So multiple pathways
Yes.
leading to high blood pressure. So what are some like telltale signs of acromegaly? Like what should people be aware of?
Well, you already mentioned the enlarged hands and feet.
Right.
Other telltale signs include prominent facial features like a protruding jaw, a brow,
Okay.
and just kind of a general thickening of the soft tissues.
Okay. So some pretty noticeable changes. Overall, how's it diagnosed?
One key test is measuring the levels of IGF-1,
Okay.
which is a hormone produced in the liver in response to growth hormone.
Okay.
So if IGF-1 is high, that raises a red flag.
Okay.
And then, to be extra sure, doctors often do what's called a growth hormone suppression test.
Another challenge test.
Another challenge test, yes. So you drink a sugary drink, which should normally suppress growth hormone production.
Okay.
But in acromegaly, those growth hormone levels stay high.
Right.
And it reveals that something's going on.
So again, we're trying to trick the pituitary gland
We are.
into showing its true colors. And if it doesn't suppress,
Yep.
that's a pretty clear sign
Yes.
of acromegaly.
Exactly. And then once the diagnosis is made, then an MRI of the pituitary is usually done to visualize that tumor, see how big it is, where it's located.
Got it. Okay. Wow, we've covered a lot of ground today. Primary aldosteronism, pheochromocytomas and paragangliomas, Cushing syndrome,
Yes,
and acromegaly. It's incredible how many ways
it is.
the endocrine system can mess with our blood pressure.
It's fascinating. And we've just really scratched the surface.
Well, there's more.
There is.
Oh, no.
There are a few less common.
Don't tell me there's a whole other lineup of villains.
There are, well, a few less common, but still important.
Sure.
Endocrine causes of hypertension that we can touch on. Things like congenital adrenal hyperplasia, apparent mineralocorticoid excess,
Okay.
cortisol resistance.
Okay. I get it. The list goes on.
Yes, it does.
Before we get lost in the weeds, I'm really curious about treatment.
Of course.
What is the game plan for tackling these different conditions?
That's a great question.
Yeah.
And one we'll dive into right after a quick break.
Okay, sounds good. All right, so I'm ready to hear about treatment. Like, we've met the villains, we know how to spot them,
Right.
but what do we do about it? How do we take them down?
Well, the good news is most of these endocrine, culprits are treatable.
Okay.
And in some cases, curable.
Oh, wow, that's great.
Yeah. But just like any good detective story,
Yeah.
the approach depends on the villain.
Okay, that makes sense. So let's revisit our sneaky sodium-hoarding friend, primary aldosteronism.
Okay.
How do we stop that one from causing so much trouble?
Right. So remember how we talked about primary aldosteronism being either unilateral,
Right.
affecting one adrenal gland, or bilateral, affecting both?
Yeah.
Well, that distinction is key when it comes to treatment.
Right. So it all boils down to whether one or both adrenal glands are involved.
Exactly. So for unilateral primary aldosteronism, surgery to remove the affected adrenal gland is often the most effective solution.
We're talking about adrenalectomy, right?
Yes, exactly.
Seems pretty straightforward. Just take out the problem gland and you're good to go.
Right, and it's a very effective treatment. Adrenalectomy can often cure the condition, bring blood pressure down to normal, and even reverse some of that damage to the heart and kidneys.
Wow, so a cure. That's amazing. But what about those bilateral cases where both adrenal glands are the problem? I'm guessing you can't just take out both adrenal glands.
You're right, we need those adrenal glands.
Oh,
So for bilateral primary aldosteronism, the treatment strategy shifts to medications that block the effects of aldosterone.
okay, so instead of removing the source of the problem, we're blocking its effects.
Right.
Gotcha. So what kind of medications are we talking about? What do those look like?
Yeah, so these medications are called mineralocorticoid receptor antagonists. We call them MRAs for short.
MRAs, okay.
And they basically work by preventing aldosterone from binding to its receptors in the kidneys,
Okay.
which reduces its ability to raise blood pressure. It's like, putting a lock on the door so aldosterone can't get in and do its dirty work.
Ah, that's a good analogy. I like that.
And, the two most commonly used MRAs are spironolactone and eplerenone.
Okay.
And these are often really effective in controlling blood pressure and improving potassium levels as well.
Okay, so MRAs, spironolactone, eplerenone. Got it.
Yeah.
So we've got a two-pronged attack for primary aldosteronism, surgery for unilateral, MRAs for bilateral. But I'm guessing lifestyle changes are still part of the picture here.
Absolutely. Even after surgery or starting those MRAs, a healthy lifestyle is crucial for long-term blood pressure control.
Of course, those good old lifestyle changes, right? Never go out of style.
Nope.
All right, speaking of adrenaline rushes, that brings us to pheochromocytomas and paragangliomas, or PGLs for short.
Right.
What's the treatment strategy for those adrenaline-pumping tumors?
Yeah, so surgery to remove the tumor is the ultimate goal, just like with unilateral primary aldosteronism.
Okay.
But we have to be extra careful with PGLs because, remember, all those excess catecholamines,
Right.
they can make surgery risky. Imagine having a surge of adrenaline while you're on the operating table.
Yikes. Yeah, that sounds like a recipe for disaster. So how do doctors manage that risk?
Well, before surgery, patients are typically started on medications called alpha blockers. And these alpha blockers, they help to block the effects of those excess catecholamines, so they kind of keep blood pressure and heart rate in a safer range.
Okay, so alpha blockers are kind of like the pre-op calming agents for these tumors.
That's a great way to put it.
That's fascinating. All right, let's move on to Cushing syndrome.
Okay.
So how do we tackle that cortisol overload condition?
Treatment for Cushing syndrome really depends on the underlying cause. So remember we talked about different causes, whether it's a pituitary tumor or an adrenal tumor.
Right. Different causes, different approaches.
Exactly. So if it's a pituitary tumor that's causing the problem, then surgery to remove that tumor is usually the first-line treatment.
Okay.
And for the adrenal tumors that are causing Cushing syndrome, surgery to remove that affected adrenal gland is also typically recommended.
Okay, so surgery is kind of a common theme here.
It is.
But what happens if surgery isn't an option or doesn't completely resolve the problem?
Right. Well, there are other options too. Radiation therapy might be used to shrink the tumor, or medications that block cortisol production might be prescribed.
Gotcha.
So it really depends on the individual case and how severe the Cushing syndrome is.
All right, so a multi-pronged approach, as always. Finally, let's talk about acromegaly, that growth hormone disorder.
Okay.
What's the treatment strategy there?
Well, just like with the other conditions we've talked about, surgery to remove the pituitary tumor is often the most effective way to treat acromegaly.
So surgery again? I feel like a broken record here.
Well, it often is the most effective way to address the root cause of these conditions.
Right. It seems like removing the source of those hormonal imbalances is the way to go.
Exactly. And for acromegaly specifically, removing that tumor can really help normalize growth hormone levels, prevent further complications, and in some cases even reverse some of those physical changes that have occurred.
Wow, that's pretty remarkable. But what if surgery's not feasible for whatever reason or doesn't completely control the excess growth hormone? What are the options then?
Well, there are medications that can block the effects of growth hormone or even reduce its production.
Okay, so medication is kind of a backup plan.
Exactly.
All right, so we've covered a lot in this episode. Primary aldosteronism, pheochromocytomas and paragangliomas, Cushing syndrome, acromegaly.
It's been quite a journey.
It really has.
Yeah.
I feel a lot more knowledgeable now. But before we wrap up, I am curious.
Yes.
You mentioned some other less common endocrine causes.
Right.
Can you tell us a little bit more about those?
Yeah, sure. So we touched on a few others. There are some rarer conditions like congenital adrenal hyperplasia, which is an inherited disorder affecting cortisol production.
Okay.
And then there's apparent mineralocorticoid excess,
Okay.
which involves a deficiency in an enzyme that normally breaks down cortisol, which can lead to a buildup of cortisol that actually acts like aldosterone.
Oh, wow. So even a deficiency in an enzyme can cause these problems.
Exactly. It's all about that balance in the endocrine system.
Really?
And then there are conditions like cortisol resistance, Liddle syndrome, Gordon syndrome, which all involve different mechanisms that can ultimately lead to hypertension.
Wow. The endocrine system, it's full of surprises.
It is a very complex system.
It is.
But the good news is we're learning more and more about it all the time.
That's good.
And with early diagnosis and treatment, many of these endocrine disorders can be really effectively managed.
That's good to hear. I'm starting to feel like a real endocrine hypertension detective now.
You're doing great.
But seriously, if someone's listening to this and they're thinking, maybe I have one of these conditions. What should they do? What are those first steps?
The most important thing is to talk to your doctor.
Okay.
You know, they can assess your individual situation, review your medical history, do a physical exam, and order any necessary tests to rule out or confirm an endocrine cause.
Okay, so talk to your doctor. That makes sense. Are there any specific questions that someone should ask their doctor if they're, thinking that they might have an endocrine problem?
Absolutely. Don't be afraid to, ask about your blood pressure.
Okay.
Especially if it's been hard to control.
Yeah.
Mention any symptoms you've been having, whether it's, unexplained weight gain, muscle weakness, or any changes in your appearance. And definitely ask about those potential endocrine causes of hypertension, especially if you have a family history of endocrine disorders.
Okay, so be proactive, advocate for your health. I think our listeners will appreciate those tips.
I hope so.
Knowledge is power.
Absolutely.
Well, I think we've covered just about everything in this endocrine hypertension deep dive.
We've explored a lot of ground.
We have. We've learned about the causes, diagnosis, and treatment for these sneaky endocrine disorders that can cause hypertension.
Exactly.
Huge thanks to you for being here today and lending your expertise.
It's been my pleasure.
And to our listeners, thanks for joining us on this deep dive into endocrine hypertension. Remember, knowledge is power, so stay curious until next time. All right, so we've journeyed through this landscape of endocrine hypertension.
They have.
We've met those sneaky hormones that can wreak havoc on our blood pressure. We've even learned how doctors play detective to track them down and diagnose those tricky conditions.
Exactly.
But now for the most important question. How do we fight back?
Right.
What are the treatment strategies that can bring these endocrine troublemakers under control?
Well, that's what we're going to talk about now.
Okay, perfect. Let's start with that master manipulator of sodium. Primary aldosteronism.
Okay.
How do we stop this one from causing so much trouble in our bodies?
So remember how we talked about primary aldosteronism being either unilateral, meaning one adrenal gland is the culprit, bilateral, meaning both adrenal glands are involved?
Yes.
That distinction is super important when it comes to treatment.
Okay, so it all comes down to which adrenal gland or glands are involved.
Exactly. So for unilateral cases, surgery to remove that troublesome adrenal gland, what we call an adrenalectomy. That's often the most effective treatment.
Okay, so we're just taking out the source of the problem.
Right. Get rid of that rogue adrenal gland that's pumping out all that extra aldosterone.
Does that usually fix the problem for good?
In a lot of cases, yes. Adrenalectomy can be a real game changer for people with unilateral primary aldosteronism.
Okay.
It often leads to much better blood pressure control and, even a cure in some cases.
Wow, a cure. That's fantastic.
It is.
It seems like a pretty simple approach. You just take out the problem and you're good to go.
Yeah.
But what about bilateral cases?
Right.
Where both adrenal glands are the problem.
Right.
Obviously, you can't just take out both adrenal glands.
Yeah, we need those. Our bodies need them. So for bilateral primary aldosteronism, the strategy shifts to medications that can actually block the effects of aldosterone.
Okay, so instead of removing the source, we block its impact.
Exactly.
Makes sense. What do those medications look like?
So these medications are called mineralocorticoid receptor antagonists.
Okay.
MRAs for short.
MRAs, got it.
And they basically work by preventing aldosterone from binding to its receptors, specifically in the kidneys, and that reduces its ability to raise blood pressure. It's like, putting a lock on the door so that aldosterone can't get in and do its dirty work.
Oh, I like that. That's a great analogy.
Yep.
So we're essentially disarming aldosterone.
Exactly.
So it can't cause any more trouble. Do you happen to know the names of some of these MRAs?
Yeah, so the two that are used most often are spironolactone and eplerenone.
Spironolactone and eplerenone.
Okay, and these are often really effective at controlling blood pressure and also improving potassium levels, which we know can be messed up by that excess aldosterone.
Right, right. Okay, so we've got MRAs, spironolactone and elavernin for bilateral primary aldosteronism.
Yep.
We've got surgery for unilateral. Are lifestyle changes still part of the picture, though?
Absolutely. Even after surgery
Yeah.
or starting those MRAs, lifestyle modifications, like you said earlier, are super important for long-term blood pressure management.
Yeah, they really are.
Yeah.
It's all about creating that good foundation, right?
Exactly.
For those treatments to really be their most effective.
Yeah.
All right, let's shift gears now and talk about those adrenaline-pumping tumors, pheochromocytomas and paragangliomas,
Right.
PGLs for short.
Yep.
How do we actually treat those?
So for those tumors, surgery to remove them is the ultimate goal,
Okay.
just like with unilateral primary aldosteronism.
Uh-huh.
But as we talked about before, those excess catecholamines, the adrenaline and noradrenaline,
Yeah.
can make surgery a little risky.
Right, because nobody wants an adrenaline surge while they're on the operating table.
Definitely not.
So how do surgeons manage that risk?
Well, before surgery, patients are typically started on medications called alpha blockers,
Oh.
and these help to block the effects of all those excess catecholamines, so they help keep blood pressure and heart rate in a safer range.
Okay, so alpha blockers are like the pre-op chill pills for those tumors.
Yeah, that's a good way to think about it.
That's really interesting. Okay, let's talk Cushing syndrome.
Okay.
What's the treatment strategy there?
So treatment for Cushing syndrome really depends on the underlying cause.
Okay.
Is it a pituitary tumor?
Yeah.
Is it an adrenal tumor?
Right, different causes, different approaches.
Exactly. So if it's a pituitary tumor causing the Cushing syndrome, then the first line of treatment is usually surgery to remove that tumor.
Okay.
And then for adrenal tumors causing Cushing syndrome,
Uh,
surgery to remove that affected adrenal gland is also usually recommended.
okay, so surgery seems to be a recurring theme.
It is.
But what if surgery isn't an option for whatever reason,
Right.
or it doesn't completely take care of the problem? What are the other options?
There are other tools in the toolbox, so to speak.
Okay.
Radiation therapy might be used to try to shrink the tumor,
Okay.
or medications that block cortisol production might be prescribed.
Gotcha.
It really depends on the specific situation and the individual patient.
All right, so another multi-pronged approach.
Exactly.
Okay, last but not least, let's talk about acromegaly,
Okay.
the growth hormone disorder.
Right.
What's our game plan for treating that one?
Yet again, surgery to remove that pituitary tumor often takes center stage.
Surgery, surgery, surgery. Seems like it's the go-to solution.
Well, it often is the most effective way to kind of get to the root of the problem.
Right, right. Removing the source of those hormonal imbalances.
Exactly. And for acromegaly specifically, removing that tumor can often help normalize those growth hormone levels, prevent further complications, and even, reverse some of those physical changes that have happened.
Wow, that's amazing. But like with the other conditions, I'm assuming there are sometimes cases where surgery is not an option.
Right.
What do we do then?
If surgery isn't possible, or if it doesn't fully resolve the issue,
Yeah.
medications that block the effects of growth hormone or even reduce the production of it can be used.
Okay, so medication as a backup plan. I feel like we've learned so much today
We have.
about primary aldosteronism, pheochromocytomas and paragangliomas, Cushing syndrome, acromegaly.
It's been quite a journey.
It really has. But before we sign off for today,
Yeah.
I want to make sure our listeners know what to do if they suspect they might have one of these conditions.
Absolutely.
What's the first step?
The most important thing is to talk to your doctor.
Okay.
Don't be afraid to share any concerns that you have about your blood pressure,
Right.
especially if it's been hard to control or if you've noticed any unusual symptoms. Early detection is really key when it comes to endocrine hypertension, so don't be shy about asking questions.
Absolutely. It's all about being proactive and advocating for your health.
Exactly.
Well, I think we've covered just about everything there is to cover on endocrine hypertension.
We've explored a lot.
We have, from those sneaky hormones
Right.
to the treatments that can get them back in line.
Absolutely.
A huge thanks to you for taking the time to be here with us today and for sharing all of your expertise.
It's been my pleasure.
And to our listeners, thank you for joining us for this deep dive into endocrine hypertension. Remember, knowledge is power when it comes to your health. So stay curious, and we'll see you next time.